All right, I'm going to get started with introductions. Again, thank you so much for joining. I know this is a tough time for families. So I'm Becca Bell. I'm a pediatric intensive care doctor at UVM Children's Hospital. So I work in the pediatric ICU here. And I'm currently the president of the Vermont chapter of the American Academy of Pediatrics. And with me today, I have Stephanie Winters, who is our executive director of the Vermont chapter of the AAP, and she's helping us with tech issues. And we're so lucky. I feel so lucky to have my colleague, Dr. Leah Costello, here with us today. So Dr. Costello is a pediatrician at Timberlane Pediatrics. And what we're going to do is Dr. Costello is going to give us about 15 or so minutes, 15, 20 minutes of a slide presentation of information about the vaccine. And then the rest of the time is open to questions. So this is a webinar format. So the way that works is you can type your question into the Q&A section and you at any point, and I'll keep an eye on that while Dr. Costello is talking, and then we'll sort of gather all the questions and start answering all the questions once Dr. Costello is finished. So I'm going to hand it over to her. And again, thanks so much for joining.
Hi, my name's Leah Costello. I am a pediatrician at Timberlane Pediatrics in South Burlington, and I live locally here and have 3 kids in the CBSD district, or one's a toddler, but 2 in school. So I am personally very excited about this and excited to share with you guys about the research behind the vaccine, some information, and hopefully answer your questions tonight. So the main points of this chat, I may actually just need to edit something here. I'm going to have to stop screen sharing for a second. My some things are like right in the middle of the bar. Sorry. I don't know why that is. Like they're smack in the middle of my slide. Here we go. Okay. Okay, I hope you can go back to seeing the screen now. But the most common things that we've been answering in pediatrics is like, does my child need to get vaccinated? What are we protecting kids from, as we feel like this is, we know that for many kids, this can be a more mild illness. And then the biggest question is, what are the risks of vaccination? So hopefully we can kind of cover some of those broad categories tonight for you. So the COVID vaccine works like many other vaccines that your child receives. When COVID gets inside your body, it invades and multiplies inside the body. And the way that the vaccine works is priming your immune system to be ready for that, so that when COVID comes, the SARS-CoV-2 virus that causes COVID comes into your child's body or your body, that your child's immune system is ready to make special proteins called antibodies that can help fight the virus and stop it from multiplying. After vaccination, anyone who is vaccinated has a lower chance of getting COVID. That's what we're hoping for. And if they do get COVID, if they are exposed to it, they are much less likely to be as sick as they would have been without getting the vaccine. So it not only offers protection, it may decrease the risk of more serious illness as well. And it is just incredible to me that we can stand here and say that we have a highly effective vaccine at stopping people from getting COVID and preventing serious illness, hospitalization, and death from COVID. I mean, I know it's been a long, 20 something months, but holy smokes, it's just incredible that we can say that we have this really, really effective vaccine, but we don't know yet how long it will last. And part of tonight and part of just talking about vaccines is that there's things that we know and things that we don't know. And right now we don't know how long this vaccine will protect people. This will become more clear in the future. But we, and as you all know, we are getting boosters, but that's because we're still in a surge. So But that is one thing that we just don't know yet. How do we know about the vaccine for youth? And what we have seen from these studies that have been performed by Pfizer is that the COVID vaccines are remarkably safe and effective for kids 5 and up. The gold standard of vaccination studies, or of any medical study, is what's called a randomized placebo, like double-blind study, and that was performed for all stages of the COVID vaccine. And the thing about this is that people have their eye on this. So the CDC has said that this vaccine will be the most intensive safety monitoring in US history. So we are going to know if something is coming up. And so far, nothing has for ages 12, or very minimal has for ages 12 and up. And it is just remarkable that we can have that data in real time. So the history of the Pfizer-BioNTech COVID vaccine, this is the one that's been approved through emergency use authorization for kids. So we'll just talk about that, that particular vaccine. Last December, it got EUA for those 16 and older. In May, we saw approval for ages 12 to 15. In August, it actually received full approval. So it's no longer under emergency use authorization for those 12 and up. And then just recently, last week, it received emergency use authorization for the 5 to 11-year-old at a different dose, the pediatric dose that we'll go over. So what we know about this is that in the US alone, over 100 million people have been fully vaccinated with 2 doses, and 12.6 million youth ages 12 to 17 have been fully vaccinated with this vaccine. And that really allows us to say that we do feel like this vaccine is both safe and effective. So what do we know for the kids? They are going to get a smaller dose, 10 micrograms rather than 30 micrograms. And what they saw in the study is that children in this age group who got the 10 microgram dose had a similar immune response to those in the 16 to 25-year-old study group that received 30 micrograms. The dosing for pediatrics was the initial parts of the trial, and actually I think that's in a later slide, so I can go over that in a minute. But so briefly, they saw a similar immune response to adults. They saw an efficacy of 90.7% effective against preventing COVID-19 infections. And this was studied during Delta. This was done this summer and fall. And they saw no serious adverse events related to the vaccine. There was a broken arm and a swallowed penny, or a swallowed coin. I don't know if it was a penny, but obviously not related to the vaccine, kids being kids. So here we go with how this trial, how Pfizer rolled out their trial. So the phase 1 of their trial was the dose finding, and that's where they gave 10, 20, and 30 microgram doses to kids, and very quickly found out that kids had too much of a reaction to too many side effects to the bigger doses. So they quickly saw with the 10 microgram dose that the antibody response measured was similar to the antibody response seen in 16 to 25-year-olds. What we know about kids is that vaccines are not there. This is not a medicine, this is a vaccination, and it is not weight-based dosing. It's actually their immune response. And we see this with other vaccines too. So the HPV vaccine, for example, if any of you have older children, you may know that if we start the HPV vaccine at a younger age, children only need 2 doses. If we started at an older age, they need 3 doses. And that's just because children's immune system is more robust and responds more rapidly and more, not aggressively, but it just mounts a better and faster immune response. So we can get a better immune response with a smaller dose in these kids. And from this phase 1 of this dose finding study, know that they can mount that appropriate immune response without having too many side effects. So then the phase 2 and 3 of the trial, they tested completely with 10 microgram dosing. And that's where they study the safety and efficacy of the vaccine. So they randomized kids in this group in a 2-to-1 fashion. So there was about 4,500 kids enrolled in the trial total, and 3,000 received the vaccine and 1,500 received a placebo. The bottom of this talks about the 322 were studied for their immune response. So they did, one portion of the study was looking at both safety and efficacy of the vaccine, how well it worked against COVID and preventing serious complications. And then there was another portion of the study that was just for safety. How well was it tolerated and what side effects did we see? So some people, and a lot of people, kids, did not have any side effects at all. The most common side effects were the ones that's been reported in adults as well, that there was some pain at the site of the injection, some redness, some swelling. But luckily we saw like headaches and fevers and chills and some of those pretty intense side effects that you and I may have had where we missed a day of work. We actually just saw those occur at a lower rate in this age group. The most common were headache and fatigue, and most were actually mild, and they were temporary and went away within days. And these families that wonderfully volunteered to do this trial, they were given phones with that they had to answer questions like every night on how their kid was doing. So this graph looks at dose 1 and dose 2 and just redness, swelling, and pain at the injection site. And it compares both the 10 microgram dose and the 30 microgram dose. So you can see that there was a little bit of redness, a little swelling, and then pain. And we can expect that. And especially kids are going to note that pain for sure. So this graph I really like. This shows dose 2, the 7 days after receiving dose 2. The top is the kids who received the vaccine and the bottom is the placebo. And on the within each column, you can see 2 bars. The column on the bar on the left is the 10 microgram dose for kids ages 5 to 11, and the bar on the right is the 16 to 25-year-olds receiving the 30 microgram dose. So that was kind of comparison. And you can see that we've got some, and then the green is mild and the blue is moderate symptoms. And you can see that we do have some fatigue, headaches, and a little bit of chills and muscle pain in this age group, but it's definitely less than the older kids or the 16 to 25-year-olds who received the 30 microgram dose. And what I love the most about this is the amount of kids that complained of headache and fatigue in the placebo group, because I just can imagine these study directors running this trial and asking a 5-year-old, so do you have a headache? And the 5-year-old's like, yeah, of course I have a headache. Like, but because they just agree to everything most of the time. So, but this felt really reassuring to me when I looked at this and felt like, wow, I can really tell my patients that we are seeing less systemic effects from this vaccine than the older kids, and especially after dose 2. So I think the real hot ticket item, and maybe why a lot of you are here, is to talk about vaccine-associated myocarditis. So what we do know, and so again, kind of going back to we can only talk about what we know and what we don't know. There were no cases of myocarditis in the 3,000 children who received this vaccine in the trial. We do know that there is an increased risk of myocarditis in 12 to 17-year-old males after the second dose of the Pfizer vaccine. It's really rare. It is so rare. We had to give like tens and hundreds of thousands of doses of this vaccine to even see this side effect. So it was about 1 in 10,000, which is a very low rate. When I think about myocarditis and I talk about it with people, this is not a new thing that has come up with vaccines. Myocarditis is a word that has been in my lexicon since medical school. Myocarditis is inflammation of the the heart muscle. Inflammation of muscles can happen anytime after vaccines, after infection. Viruses, bacterial infections, fungal infections, they can all cause myocarditis. So anything that can cause some inflammation in your body or in your muscles, unfortunately, it can sometimes happen in your heart. And so we know that myocarditis is a complication of infections. What we also know in pediatrics is that we call it a bimodal distribution of myocarditis. So we actually see more myocarditis in young infants and then also teenagers. So this age group, 5 to 11, or just kind of this elementary school, middle school age group, actually we don't see as many infection-associated cases of myocarditis. So that's just something that we know about myocarditis. So the fact that we saw it in some teenagers after vaccine, when there may be a little inflammation in the body, and it fits with our bimodal distribution of the condition of myocarditis in kids. We don't know yet what we are going to see for 5 to 11-year-olds because we haven't seen any cases in the study. What we also know about myocarditis is that COVID-19 infection can cause myocarditis, and it can cause myocarditis at a pretty high rate, and that kids are much, much more likely to get myocarditis from a COVID infection than from vaccine. And what we also know is that the vaccine-associated myocarditis, so those teenage males that did get myocarditis, actually had a pretty short course. And what that looks like is, it's not subtle. It's not, you're not going to miss it as a parent. It was chest pain and fever, but most of them were treated with ibuprofen and resolved really rapidly. And so when I, as a parent and as a physician, weigh the risks and benefits of this, I think the vaccine is much more likely to actually prevent myocarditis than to cause it, because the vaccine prevents COVID, and COVID can cause myocarditis. So I think this just kind of the way that I look at it as a parent. So I'll say that again, that the vaccine is more likely to prevent myocarditis than it is to cause it. So, another common thing that we're asked about, not just for COVID vaccine, but I think for all vaccine, is long-term side effects. There has never been a new side effect that has shown up 8 weeks after a vaccination. So something where the child had no reaction and we felt like something months, years later was related to a vaccine. That's just not been documented. And there's just not really a biologic mechanism by which that would happen, because vaccines degrade within days, and particularly the mRNA vaccine. So Pfizer-BioNTech's vaccine is an mRNA vaccine. And I don't know if you all remember the reports of having to store it in a really, really super cold freezer. It's unstable and can break down very quickly. That's why it needs to be stored in that type of freezer, but it also breaks down very quickly in your body. So the idea of long-term or late onset side effects lasting a long time is just not something we are concerned about, not something the researchers are concerned about, and hasn't happened with other vaccines. But the trial participants, they'll be followed for 2 years. So they've been followed for more than 8 weeks post-vaccination, and they will be continued to follow as well. So we talked about some of the risks from the vaccine, but again, kind of thinking about, okay, well, we're weighing the risks and benefits of vaccine versus a COVID infection, especially right now. So what are the risks of getting COVID, and what are the risks of a COVID infection in this 5 to 11-year age group? So nationally, there's been more than 8,000 hospitalizations to date for 5 to 11-year-olds from COVID. And about a third of those have ended up in the ICU. That's stressful and scary. It's not, that's a lot for a kid to go through and a family to go through. this is from ages 0 through 18. This is unfortunately representing deaths from COVID. And as of mid-October, there have been 94 COVID deaths in this age group nationally. And like, children are not supposed to die. And now we can say that we have a vaccine that is going to prevent against a cause of death in children. That is, as a pediatrician, it just brings tears to my eyes. I can't even believe we can say this. But so while that number is small, if you think about the entire population of the United States, you just need to remember that children are not supposed to die, and children died of this disease. So that is what we are preventing. Our Vermont cases, whew, you guys, this is tough. We are just seeing more and more cases in Vermont right now, unfortunately. So on the left is just total pediatric cases are in orange, compared to the gray bar is adults, but you can see that the orange bar is just going up and up. And on the left, on the right side here with the green and purple and blue, the purple are the kids ages 6 to 11. And that bar is getting bigger and bigger. So we're just so lucky we have this vaccine now, and we can do something and turn the tide here. So, and then again, this is Vermont cases as of just the other day, and that purple bar, it's going up. So again, I'm really glad that we have the vaccine now. Vermont is still doing quite well. We do know that. We've known that all along, that Vermont does have a lower case of COVID, but that isn't in children, but that's not the case across the United States. There are some states who have very significantly higher rates of COVID in children. This is kids over 12 who've received the vaccine, and Vermont and Massachusetts have vaccinated 81% of our 12 to 17-year-olds, which is fantastic, who've received at least one dose. Sorry, not fully vaccinated, but received at least one dose. And that's as of just last week. So we are leading the nation in vaccines, and I really hope that we can do the same among our 5 to 11-year-olds. What we think about with COVID and what hospitalizes kids with COVID is something called pediatric COVID pneumonia. This can cause the low levels of oxygen in their body, and they need to be put in the hospital for help with oxygen. And some kids, those children who end up in the intensive care unit, may need additional support from machines to assist in their breathing, anywhere from something called a BiPAP machine to actually being intubated and having a machine breathe for you. So it can be very severe in cases. The severe cases are really nationally right now amongst unvaccinated adolescents. They are 10 times more likely to be hospitalized due to COVID than a vaccinated adolescent. We anticipate the same type of response going forward for these younger kids, the 5 to 11-year-old group. But again, unvaccinated adolescents are much more likely to end up in the hospital if they get COVID. And our excellent rate of hospitalization, vaccination among our adolescent age group has helped to protect us from seeing high rates of severe COVID and high rates of pediatric hospitalization as this Delta variant has taken grip here. The other thing that we can see with COVID is something called multi-system inflammatory syndrome in children, or MIS-C or MIS-C. This is a diagnosis of where the child has significant levels of inflammation. They're quite ill and require hospitalization, and they need to have more than 2 organ systems involved. The heart inflammation or myocarditis may be one of them, and it can be very severe. There have been 48 deaths among kids from MIS-C, and there has been 5,500 cases in the United States. MIS-C, so this overwhelming and kind of inappropriate inflammatory response by your body to a COVID infection. The COVID infection itself can be very, very mild. This is something that shows up later. The highest rate of presentation of this severe complication of a COVID disease is in 5 to 11-year-olds. So by age group, if we look at 0 to age 20, you can see right in the middle, 5 to 11-year-olds are the most that get MIS-C. And so hospitalization affecting 2 organs, overwhelming inflammatory response. These kids are sick. And this is the age group where we can now offer a vaccine to protect against COVID and protect against MIS-C. So the benefits of vaccinating kids and what we might prevent in kids 5 to 11, that we are really likely to prevent a significant amount of hospitalizations, MIS-C, and intensive care unit admissions. So by vaccinating, for every 1 million children vaccinated, this is what we would prevent, which is remarkable. Weighing the risks and benefits of vaccination in this age. So this was not taken lightly by the FDA and CDC. Clearly, they had a month to review the data. They had day-long meetings to discuss the data. They really weighed the risks and benefits of this vaccine. And they really weighed it in the context of what is the right thing to do for the child, not to end the pandemic, not to help us move towards more open restaurants or more ability to travel. That wasn't in their thought process. It was really, what are the risks and benefits specifically of this vaccine? And so they really looked at thinking about the benefits of this vaccine versus the risks. The benefits being preventable COVID cases, preventable COVID hospitalizations, preventable ICU stays, and preventable COVID deaths. The risks, they really felt like probably the risk that we just don't know about right now is myocarditis. And so they assumed in their kind of risk and benefit analysis that just to make an assumption and kind of think about this and be able to think about it really for the protection of these kids is, what if 5 to 11-year-olds, what if they were questioning, they had the same rate of myocarditis as the teenagers, the 12 to 17-year-old. And looking at that risk, kind of comparing that and thinking about it, they still came to the conclusion that the benefits of this vaccine far outweigh the risks, and that this was the appropriate thing to do for kids, not for the pandemic or for the parents. It was the appropriate thing to do for the kids. The things we can't consider when we think about that risk-benefit analysis is hospital stays. If a child, the few children who did have to be hospitalized after vaccine-associated myocarditis was significantly shorter than for a COVID infection. And also really, truly, the vaccine-associated myocarditis cases that have been reported are just much more mild than infection-induced myocarditis, so myocarditis from COVID infection. The other things that we just can't consider or don't have a numerical value are transmission of this virus by kids to other kids, to infants, to family members who are still high risk. The biggest one we can't put a number on is the disruption of in-person learning due to illness and exposure. And then the other things that we can't really consider in the risk-benefit analysis are the post-COVID conditions. Actually, they weren't even really talked about in the FDA analysis, but kids can get long-haul COVID. And again, if we have something that can prevent that from happening, that is in your child's best interest. And so then the FDA voted on this question: based on the totality of the scientific evidence available, do the benefits of the vaccine when administered as a 2-dose series, 10 micrograms each, 3 weeks apart, outweigh its risk for use in children 5 to 11? That's what they were looking for. Really, do the benefits outweigh the risks in this age group? that is what they voted on when they authorized the emergency use authorization. This slide talks about why the vaccines based on age and not weight. I kind of talked about that a little bit earlier, but that younger children's immune systems just need less prompting to respond. So the dose is based on immune system maturity rather than weight. And then we just have to have an age cutoff. What about our little kids? I have a 2-year-old. Clinical trials are underway for children ages 6 months and up. Smaller doses are being tested in that age. Pfizer has said that hopefully we'll have some more of a timeline and more data by the end of this year. So by the end of December, that we might have more information about what the data looks like for them and when can we expect that to go forth to the FDA. So what about getting other vaccines? Kids are always due for vaccines, particularly those 11-year-olds. We have a few vaccines that they're due for, and then yearly flu vaccines are also available right now. This is a great time to make sure your child's caught up on vaccines. Yes, you can get the vaccines together. You can also get one on a Thursday and another one on Saturday. There does not need to be any separation in time between any vaccines, including the flu vaccine and the COVID vaccine. So medical professionals, myself included, across the country are worried about the flu season. We saw very little flu this year. I'm sure most of you are parents who have been experiencing a kind of wild ride to the start of school with infections that we just don't typically see in August, September, October. We see them in the winter. We are just having so many colds this fall, not from COVID, but other illnesses too. And we're just kind of bracing for a flu season that's going to be a little harder. So we strongly encourage flu vaccines as well. Just a couple other points. It takes about 2 weeks after getting that second dose of the mRNA for your body to have an appropriate immune response. So we say 2 weeks post the second vaccine is when they're considered fully immunized. And COVID vaccines are free, whether or not you have health insurance. Right now, you can sign your child up for vaccines through healthvermont.gov/myvaccine. Pediatricians and family medicine clinics will be able to order the vaccine on Wednesday of this week. We are not sure when we'll get them in. Most practices that I'm aware of are waiting to even schedule appointments until they know how much vaccine they got in. We will be getting enough vaccine for everybody as a state, but we're going to get weekly shipments of the vaccine. And so the supply is kind of limited in that way. But and some pharmacies also have the vaccine too. So, and school-based clinics started today. School-based clinics are a great way to get your child vaccinated. Those are going to be available through that healthvermont.gov website, where you can schedule an appointment, or you can call the phone number on the screen here. So several resources for families. Hope maybe we could put them in the chat for you. But some of my favorites are healthychildren.org. I also really like Children's Hospital of Philadelphia, CHOP. Vaccine Education Center has great information about COVID vaccines as well. So this is the end of the presentation. These are actually my kids. My 2 elementary school age kids got their vaccine the other day. They were supposed to go midday today. I would have had to take them out of school, but I learned at 8 p.m. on Thursday night there was a dose available, and we took them in their pajamas to get their vaccine. And so my reasons for vaccinating these 2 who are low risk, like my family's very healthy. My parents who live nearby are very healthy. We are a low risk family. I feel like if they were to get COVID, I would most likely it would be a pretty mild infection. There's a small risk they could be hospitalized. There's a small risk they could get that MIS-C, but overall low risk. But there are so many reasons I was just thrilled for them to receive this vaccine. One, I felt as a parent like the risks of this vaccine were quite mild. I trust in vaccine science. There's decades and decades of research on vaccines. I give vaccines every day for the last like 14 years since graduating from medical school. I give vaccines. I just really trust in this amazing thing that we have to protect our community. And I trust in the science that went into the COVID vaccine. And I felt like the risks of this vaccine were really small to my kids. And the benefits are just incredible. It does prevent that rare case of MIS-C, but mostly it prevents them from missing school. I can't even put a number on, days of school missed for like exposures or just illnesses or the missed school that they had last year. Like, I don't know what that risk does to them over a lifetime. I want them to be able to be with other kids. I want them to be able to protect their community and know that this isn't just about us and them. This is about protecting our whole community, that we have friends whose they both have friends whose parents have immunocompromising conditions. They're at school with kids who have young siblings. They have a young sibling, that they can help to reduce people's risk around them too. And they were excited to get this. They were really tired. They got it about at 8:45 at night, and my husband offered them an ice cream and they said no. So I think they were just exhausted, but they were excited to get this vaccine, and they know that it means that some good changes are coming. And for me, the benefits of the vaccine far outweighed any risk. And clearly I brought them in the very first day it was available in their pajamas. So this is our shot, Vermont. So let's take some questions and answers.
Thank you so much, Dr. Costello. I'm going to give you a breather, let you take a sip of water. And we have some really great questions rolling in. So I might start with a couple. And so a few came in at the beginning, and you may have answered the questions, as you went along, but we're still going to review them and go over them just to make sure that that folks have the all the answers to their questions. So there was a couple questions related to size of the child and the dose. So one aspect of that is, will the vaccine be effective since it's a smaller dose? And so that question, Dr. Costello had answered by saying that when they compared, the researchers compared the antibody response and compared it to the 16 to 25-year-old data, that was the same. And then just so folks know, they did actually split it up by age in that group. So the 5-year-olds, the 6-year-olds, the 7-year-olds, the 8, and the 5-year-old response was the same as the 11-year-old response, because that's a question that people have had. Well, if they're 11, should we wait? They're turning 12 in a month. Should I wait until they turn 12 and get the vaccine then? And the answer is no, because we know there's great response in 11-year-old. And there's a lot of COVID out there now. So we're recommending that everyone get the vaccine as soon as possible and get the dose based on your age. Folks have also asked about, again, what if you're a really small 5-year-old? And I think when we think even about the adult population, I think we can all picture 2 different adults, and that could be maybe 3 times the size of each other, right? That get the same dose of a vaccine. So again, it's not really a medication where it has to kind of distribute throughout your body. It's a catalyst for your immune system to give your immune system some information. So again, it's based on the age. Even if you have a small 5-year-old, even if you have a big 11-year-old, get the dose based on their age. And Dr. Costello, I don't know if you have more to add to that.
I would recommend getting it as soon as possible. No,
yeah.
But yes, and that agree with Dr. Bells.
There's a thanks in here for Joan, who is doing ASL interpretation. So thank you, Joan. There's a question in here about myocarditis that came in before you got to that part, but I think we can review it again because this is actually a really good and specific question. So there's somebody who's ready and eager to get their child vaccinated, wondering about spacing out the second dose. Would that help with risk of myocarditis, and recognizing that this person recognizes that there's no data from a study, but had read somewhere that there seems to be less reaction to the vaccine if the second dose is spaced farther apart. So I'm wondering about that.
That's a great question. And you're right. We don't, in the things we know and don't know, we don't know if that reduces risk. But what we do know is that it increases the risk of getting COVID, especially right now with our really high rates among this age group, that the further that we delay vaccination or further delay that second dose, you leave your child vulnerable to COVID infection. And that we know also increases their risk of getting myocarditis at a higher rate than the vaccine associated myocarditis. So my kids will be getting it, actually 3 weeks is Thanksgiving. So we have an appointment a little bit later, but that's just because of the holidays. So,
yeah. And I think I'll add a little bit more to that because that it sort of leads into another question that somebody brought up. So again, talking about what we know and what we don't know. And Dr. Costello hinted at or addressed some of this, is that we have reason to believe, although everyone's being very cautious in saying so, that we expect that the risk of vaccine-associated myocarditis will be even less, like even more rare in the 5 to 11-year-old age group than in the older adolescents and young men. Why do we think that? So one is the incidence of vaccine-associated myocarditis is a little bit higher in 16, 17, 8-year-olds than in the 12 to 15-year-olds. So it seems like that might be a peak age. In myocarditis not associated with the vaccine, but regular viral myocarditis, that's what we see too. We see like a peak incidence in male adolescents. We see a pretty low incidence of myocarditis in general among 5 to 11-year-olds. It seems like the vaccine-associated myocarditis is sort of following in terms of its incidence with the patterns that we see in baseline, say, viral-induced myocarditis. So that's one reason. The second reason is that, again, and we don't know this, but the dose is smaller. So one of the thoughts is perhaps there will be less vaccine-associated myocarditis. And again, we don't know because there was no cases of myocarditis in this vaccine trial, but we know that it happens so rarely that we wouldn't expect to see it in 3,000 people. We know that even at the 16 to 17-year-old males, it's only 1 in 10,000. So you have to actually vaccinate hundreds of thousands or millions of people to actually see it. And I am explaining all that because that leads into a question that I wanted to address, because I've suddenly seen it a lot in a lot of sort of misinformation on social media, is a quote by one of the FDA during the FDA discussion, which I watched, and they were sort of talking about exactly what I was just talking about, which is, will the 5 to 11-year-olds have a lower rate of vaccine-associated myocarditis? Here are the reasons we think that might be the case. They usually have it at a lower incidence anyway. The dose is smaller, but we don't know. So being really clear, we don't know. And that's why we have all these monitoring systems in place to watch. So we won't know really what the rate of it is until probably millions, hundreds of thousands of children are vaccinated to actually even see that 1 in 10,000. It could be, 1 in 10,000, 1 in 100,000. So the quote that keeps making the rounds in certain social media circles is that one of the folks on the during the FDA discussion said exactly that. We're not going to learn about how safe the vaccine is unless we start giving it. That's the way it goes when we're talking about very rare events. But it's interesting because I watched the debate, but for some reason that quote has been pulled out and like gone all over the internet as something that sounds like an experiment. And that's another word that's been used a lot on social media, is the word experiment. And I want to be really clear about what an experiment is and isn't. So the clinical trial is an experiment, and the people who participated in the clinical trials, you know, went through this whole consent process. And I have to say that the folks involved in these clinical trials were inundated with requests to participate, both when they were, you know, had clinical trials for adults and with children. And many physicians in particular really wanted their children to be part of clinical trials. So this is not an experimental vaccine. This has been authorized for use by the FDA, and it has been recommended for use by the CDC for this age group. So it's not an experiment. So another question is, there's a bunch of thanks. Thank you. Here's another good question. It actually talks about the clinical trial. So out of the 3,000 kids in the study, how many were African American? Are there any additional concerns for kids that are African American?
You know, I actually don't know that data. I know that they really tried to have a very representative group. And I did look very specifically at kids with special healthcare needs, that was well represented with asthma, obesity, and other illnesses in kids that might put them at more risk for complications from COVID specifically. But I actually did not see any of the demographics of I don't remember. Do you remember?
So I do know for the clinical trials, they take very, very special care to match the demographics so it can be nationally applicable and representative. So the clinical trials are generally very good at doing that. And I suspect that's something that we can look into and look at the clinical trial website and see what the breakdown for demographics is. There is a disproportionate percentage of both cases and hospitalizations among BIPOC children when you look both in Vermont and nationally. And the thought really is
COVID infection.
From COVID infections, thank you. Yes, from COVID infection. And the thought really is that there's a lot of reasons why children are getting exposed to COVID more. They might have family members who, based on their work early on in the pandemic, for instance, were working in person. And so there are a lot of risk factors there. So there's they're definitely disproportionately affected by COVID infection. What happens if a child gets sick with COVID between the first and the second dose?
They can still get their second dose. They just may need to delay it until they're out of isolation from their COVID infection. That would be a bummer, but I'm sure it does happen. But yes, they could go on to get their second dose. And I think this actually gets to the point that we didn't have in the slideshow. But what if your child had COVID in the past? Do they need vaccine? So when kids have disease-acquired immunity or immunity from getting the infection, we actually just don't know as much how long that lasts, how effective it is. And your immune system has memory. And so it will remember that particular strain of COVID and could maybe offer some protection for a little while against that particular strain of COVID. But the vaccine offers longer immunity. We know the dose of vaccine that we're giving. We know the antibody response. And it also can offer protection against multiple strains of COVID. So even if a kid has had a COVID infection, we don't feel like their immunity is quite the same as immunity from vaccine. And we still recommend that those kids, as soon as they're out of their isolation from their COVID infection, get the vaccine.
And there's another question related to that that I'm just going to add on to this, which is, what are the risks of a child who has antibodies from infection, and then they get vaccinated? Could that actually interfere with something that's happening in the body?
That's a great question. No, it would not interfere. There are different types of vaccines, and the reason that your child can't get a measles vaccine until typically 1, if there's a risk factor, they might get it at 6 months, is that in those live virus vaccines, measles, chickenpox, the mom's antibodies can actually still be present in the infant, and can cause a dampened immune response to the vaccine. So in that particular group of vaccines, yes, but COVID vaccine is not a live virus vaccine. It's this mRNA vaccine. And so antibodies present from the COVID vaccine already would not attack the mRNA. It would not dampen your response in any way to the vaccine because it has a totally different mechanism of action. But that is true for some vaccines. So that is a really good question. And I haven't been asked that yet. I like that one.
There's another great one, and I'm so glad someone asked because this is a very common question. Can you tell us more about how the mRNA works? Does it alter the DNA in the body?
So, no, mRNA is a messenger. It cannot get into the nucleus of the cell. So that's where your DNA is. That's your building block, your brain of the cells in your body. mRNA can send a message to the DNA to make the spike proteins. That's the protein that the mRNA is coded to make. But the mRNA just degrades very quickly. It never gets into the nucleus of the cell. It does not alter your DNA in any way, but it can send a message to the DNA. There's an excellent video that's on healthychildren.org, I believe, that it really explains. It was put out by the AAP, how mRNA vaccines work. That was really good and well done. So
you do have lots of folks just saying thank you, and I'm excited to get my child vaccinated soon. Here's
one that came up so much when we did this in the spring for 12 and up, and I'm kind of excited that it hasn't come up a bunch because there's just no plausible biologic mechanism, but is fertility. And it's exciting that question hasn't come up, that most people, I think, can see that we have vaccinated thousands and thousands of pregnant women with no adverse effects to the fetus. This vaccine just has no biologic mechanism to affect fertility in kids. And that was, I think, the most common question that we had in the spring for 12 and up. So
another really good question. What about, is there any data regarding underlying issues that may be associated with a higher likelihood of vaccine-induced myocarditis? My kid has a heart murmur, unsure if that makes them more likely to experience that. And I can answer that.
This is an excellent, I actually spoke with one of our local cardiologists the other day just to talk with him a little bit about myocarditis. And he said what, I should have said this earlier, I forgot. He was like, I want folks to know that there's a large network of pediatric cardiologists that all work very closely together. Boston Children's being one of them with Vermont, with the Vermont group, but across the nation. And universally, this group of pediatric cardiologists is recommending the COVID vaccine for their children with the most complex, with all pediatric heart conditions, but they are very specifically recommending it for their kids with the most complex heart diseases. So if a pediatric cardiologist is telling their patients with heart disease to get this vaccine, I think we can say that there is really no group that has a higher risk for heart associated, vaccine associated myocarditis. And that the risk of infection, again, far outweighs the risk of the vaccine for those patients.
another great question about what about just one dose? So do kids get some immunity after the first dose? Yeah, do we have any information on that?
I don't think we do have any information on that.
Yes, yeah,
hopefully they do get a little bit, and that we don't see those cases between dose 1 and 2, but we did see that with some 12 and up, that some people did get COVID between dose 1 and 2. I don't have numbers though.
Yeah, so they in the big adult trial that they looked at this actually. And so this was pre-Delta, earlier on, and found, and the problem is that it's there's a wide variety in sort of how people's immune system responded to just the one dose. And so they were sort of quantifying it, but I think it's not helpful data right now with Delta. And the study really, since that study where they really said we really need 2 doses, if anything, Delta has made it clear that we even more so need 2 doses. And so I don't think they even have really looked much at what things look like after just 1 dose. So we just don't know. We don't have that info. So I think this may be somebody, if you could just summarize quickly, because this is a recent question, and maybe somebody who joined late, what are the side effects from the vaccine in kids?
So the most common side effect is pain at the injection site. But then the other side effects can be a little more commonly, we saw fatigue, headache, and chills, less fever. They compared the kids ages 5 to 11 to folks ages 16 to 25 who received the 30 microgram dose, and saw less side effects in the group, in the pediatric dosing. But so those were the most common, and most of them were mild, some moderate, but I think actually most kids continued to go to school. My kids went to school the next day. So.
Yeah, I think we'll have much less missed school days, at least like looking at the data from the trial, those reactions were much more mild. There was a question in here about transmission. So we had mentioned in one of the slides that when the FDA and CDC independent advisory groups voted for this vaccine, really what they're looking at is like, what is this vaccine going to prevent in this child, in this age group? And what are the potential risks? We did not see myocarditis, but we know it can happen. Let's plug those numbers in and assess the risk and benefit. So one of the things that they didn't really take into account in that modeling was what other effects do children have who can get COVID and then potentially spread it, right? So we had mentioned that in a slide. So somebody did ask about, if we don't know what the effect on transmission with someone who's vaccinated, how is that sort of helpful? And so I do just want to remind folks that this vaccine was found to be 90.7% effective against COVID-19 infection, and people cannot transmit COVID if they're not infected. So I think that's an important part when we're learning about people who are vaccinated who do get COVID and that they can transmit it. We know that pathway definitely can happen. It's much less likely though. And if someone's much less likely to get infected, they're much less likely just overall to be a source of COVID to their community. So I would just keep that piece in mind around transmission. Here's a great question. Do you recommend holding off on Tylenol for kids until after 24 hours?
I don't. I typically I don't think Tylenol prior to the vaccine. That does not prevent the pain of a needle going in. It doesn't reduce any side effects. And I don't know specifically for the COVID vaccine, but in some other vaccines, we feel like it could blunt the immune response. But most specifically, it just doesn't help anything. So we don't need to be giving our kids a medicine that they don't need. And so but But if your child doesn't feel well that night after getting the vaccine, just follow your parent instinct. Like use Tylenol or ibuprofen if you feel like they need it. That's totally fine. So.
Well, I think we're actually winding down with most of the questions, and it's been an hour, and I want to thank folks for joining. We had over 50 people on the call. Some folks were asking how many people joined. There were some questions about slide sharing, and this is being recorded and will be posted on our website this session. Many of these graphs and charts can be found on the FDA and CDC website. And if you have further questions about specific slides or info, please contact us through our website, and we're happy to try to get some of those answers out to everyone, because this is really important. And our plan is to continue to do these about twice a week throughout November, throughout December. So please let friends and family know. They can watch this recording, which will be up on our website in the next couple of days. And please reach out to your own child's medical provider if you have more questions. Dr. Costello, did you have any parting words?
Hey, thanks for joining tonight. I like to tell my patients I'd never recommend anything for you that I don't recommend for my own family. And as you heard in this, I've already gotten my children vaccinated. But I also actually just it's okay to have questions and feel some hesitancy. I think there's been a lot of decision fatigue over these last 20 months, and this is just yet another decision. But I hope this was helpful. I hope you can continue to find information that's helpful. And for every article that you may question or that induces some fear in you, please seek out an article that helps to kind of scientifically explain why we feel like this is safe and effective. And your physician can help lead you to that, or healthychildren.org, the American Academy of Pediatrics website can help, or Children's Hospital of Philadelphia Vaccine Education Center would be good resources to start. But it's okay to not be first in line. There's a lot of people who were very excited too. It's okay to continue to seek some information and do information gathering like you're here tonight. So.
Thank you all. Have a good night.
Thank you.